Dr. Arzubi, it flipped over to the non-presenter view.
Okay,
There you go.
great. Let me know when we're ready.
We are 102, so let's get her going.
All right. Well, thank you everybody for joining. Again, my name is Dr. Eric Arzubi, and today we'll be going over ADHD and learning disabilities in youth as part of our child psychiatry clinic. Let me advance. Here's a disclosure, our disclosure statement, and the slides will be available, so you'll be able to read the details related to the disclosure statement. And in terms of our learning outcomes today, and for the clinic in general, during this clinic, you will learn how to describe the epidemiology of child psychiatric disorders, discuss the approaches to assessing and diagnosing childhood psychiatric disorders, determine specific best practices to implement in the treatment of childhood psychiatric disorders, including pharmacological and non-pharmacological approaches. So again, today we'll be talking about ADHD, learning disabilities, and one of the things that's important to keep in mind here is while most of us will work with children who present with ADHD because they're struggling, I think it's also important to keep in mind that a lot of kids with ADHD, and well, all of them have some strengths and some pretty robust strengths that I think is important to keep in mind. So while kids will present with ADHD, I think it's important to keep in mind that there are strengths, and we need to do our best as professionals to play to the strengths of these children. So again, really making sure we're celebrating different thinking styles. And kids and people in general with ADHD are sometimes more open to risk taking and innovation, and they can be really valuable when it's applied to problem solving. And our job as professionals and mental health professionals is to really help children function as their brain controls mature over time. So diagnosing ADHD. So again, ADHD stands for Attention Deficit Hyperactivity Disorder. Some folks still call this ADD, but again, the full name is Attention Deficit Hyperactivity Disorder, or ADHD. And it's important to keep in mind a few things. In general, the ADHD diagnosis can occur before the age of 12, and the symptoms need to be in place for 6 months, and they need to be happening in 2 or more settings. So in general, with kids, as you can imagine, those 2 principal settings tend to be the home or school. The other thing that's important is that, like any diagnosis in the DSM-5, there needs to be clinically significant impairment. In other words, just if somebody shows up or parent says, "Hey, look, my kid has ADHD, we need medication," it's fine. Again, the diagnosis comes from looking at the list of criteria, but it's important to understand that impaired functioning has to be one of them. So, somebody presents and let's say you get a 10-year-old who is brought to your office for problems related or for ADHD. Let's say they're getting B's in school, functioning okay at home, but mom or dad say, "Hey, I think my kid needs a stimulant to do better." Well, again, if there's not significant impairment, there's no diagnosis. The other thing that's important is that these symptoms can be better explained by other disorders, so like anxiety disorders, depressive disorders. And there are three types of, the important thing to keep in mind too is that there are three types of ADHD. The three types are the hyperactive impulsive type, which is kind of the one that probably most often comes to mind as sort of a young child, running around, jumping up and down, not able to stay seated and focus, and being very restless. The other type is the inattentive type, and then the third type is the combined type, which, as the name suggests, it's combined both hyperactive impulsive type along with inattentive type. There are, and in order to diagnose someone, there have to be 6 symptoms present, and they can be 6 symptoms of inattention if you're diagnosing the inattentive type, 6 symptoms of hyperactivity, or it can be both if you're looking at the combined type. The DSM-5 provided some updates in that they provided for the diagnosis of ADHD in adults and with 5 symptoms, and they also provided some relevant examples to help diagnose across the lifespan. So, just reviewing the different symptoms that are listed as the criteria. So, the inattentive symptoms here, you'll see there are 9. Lacks attention to detail and makes careless mistakes. Problem sustaining attention, doesn't seem to listen when spoken to. Poor follow through, difficulty organizing, avoiding tasks that require sustained mental effort, losing things, easily distracted and forgetful. The hyperactive impulsive symptoms, again, there are 9 of these. Blurting out answers before questions completed, running, climbing excessively, or restlessness in adolescence, difficulty staying seated, difficulty engaging in quiet activities, constantly on the go, talking excessively, interrupting frequently, difficulty awaiting turn, and fidgeting. And again, remember what I said before, there are lots of reasons people can have any one of these symptoms. That's why it's important to keep in mind that we need at least 6 of these symptoms, have to be in place during at least 6 months, and have to cause impairment in functioning. So its origins, if you remember, the definition of executive functioning, that's sort of what the front part of the brain, the frontal lobe, is responsible for, and it helps with again, making decisions, focusing attention, and so forth. So as you can imagine, ADHD represents an executive function deficit. So it's problems regulating dopaminergic and noradrenergic circuits. So essentially, these are the neurotransmitters that are affected. 76% heritability. It's associated with low birth weight. It's associated with substance exposure in utero, brain injury, early deprivation, preterm birth, and exposure to organophosphate pesticides. So these are all reasons, possible sources of symptoms related to ADHD. The big picture, there's the prevalence. The prevalence is among boys is much more pronounced than in girls, and the prevalence rate is around 6 to 9% overall. Many of these symptoms persist into adulthood, but as typically the hyperactive and the hyperactivity piece is not really carried over into adulthood as much as some of the other ones like inattention. Long-term consequences, there can be higher rates of accidents, like traffic accidents, like marital problems, unemployment, criminal behavior, and obesity. And again, these are long-term consequences of untreated or undertreated ADHD. Can lead to lower household income and higher rates of attempted and completed suicide. And then the other piece I want to call everyone's attention to is the fact that in adolescent females, and this is sort of, I've looked at the literature, but also this is based on my clinical experience. I've seen that adolescent females will often present with anxiety or depression, and upon further questioning, when you start asking about symptoms of inattentive ADHD, they're there, along with problems functioning in school and at home, and they're there as well. And so sometimes what will happen is these adolescent females will be diagnosed with anxiety or depressive disorders, will be treated as such for years without really focusing or discovering the problems with that are related to ADHD symptoms. And the other piece, sorry, as we know, one of the, a big problem among adolescent girls can be self-harm. It turns out females with ADHD have a higher likelihood of engaging in self-harm than females without ADHD. So again, all kind of important pieces that that'll help hopefully paint a more robust clinical picture when working with adolescent females. Comorbidities. So language and learning problems is 25 to 35%, and I've actually seen it as high as 50% in terms of learning disabilities. ODD, so oppositional defiant disorder, 55 to 85%. Substance use disorders over time, again, especially in untreated or undertreated patients, the substance use disorders can be a significant problem. Cognitive disorders, 10 to 20%, anxiety disorders, 33%. And then you also have tic, mood, and sleep disorders that will show up in conjunction with ADHD as well. Differential diagnosis. Again, these are other disorders that can present with symptoms that could look like ADHD. So again, they can be disruptive behavior disorders. For example, like we mentioned, ODD or opposition defiant disorder. The other one can be DMDD, which is disruptive mood dysregulation disorder. Anxiety disorders, mood disorders, adjustment disorders, certainly developmental speech or language disorders, reactive attachment disorder, substance use disorders. And importantly, I've been seeing this more and more, is kids exposed to chronic toxic stress or adverse childhood experiences have a hard time regulating themselves, either regulating physical, behaviorally or physically. And so it looks a lot like and presents like ADHD. The multimodal treatment of ADHD study, the MTA study, is the most important, kind of the most significant ADHD study that we have. It was a study that looked at 600 children aged 7 to 9 and had these different arms of the study. One was intensive medication management, which really the focus was methylphenidate or Ritalin. Next was intensive behavioral treatment alone. And then there was combination treatment, which was both medication management and behavioral treatment, and then routine community care. Turns out that combination treatment and medication management, these two interventions were superior to behavioral management alone or community care alone. So in other words, if you had meds, so medications alone or medications plus behavioral interventions, that was better than just behavioral intervention alone or care as usual. Combination treatment stood out in certain areas like opposition or aggressive symptoms, anxiety and reading achievement, as well as parent-child relations and social skills. So again, that's combining medication management as well as behavioral intervention. Only 4% of patients stopped medications due to adverse effects. And interestingly, when there was combination treatment, the actual dose of medication required was actually lower than medication management alone. So again, in medication management arm alone, it was 32.3 milligrams per day, whereas it was lower in combination treatment at 28.7 milligrams a day. Again, it's a small difference, but it's a difference. At 8 years of the study, patients returned to community care. So right after 14 months of treatment, patients returned to community care, and then over time, across the 8-year span, interestingly, there's no outcome difference among original treatment groups at 8 years. The MTA group was able to maintain improvement, but still functioning less well than folks that never got diagnosed with ADHD, which was the sort of one of the control samples. So again, improvement is possible, but we can't necessarily hope for quote unquote normalization. The kids with the best prognosis were kids with behavioral, socioeconomic, and intellectual advantages, and the ones who responded well at the initial phase of treatment. So big picture in terms of medication management and treatment, there are two families of stimulants, right? There's the Adderall family and the Ritalin family. And there's no research to show that one is better than the other. So you can start with either methylphenidate or amphetamine products. So again, either Ritalin or Adderall family. The Adderall family is approved for 3 years and up by the FDA for ADHD, and the Ritalin family is approved for 6 years and up. But as you can imagine, they are used interchangeably when starting treatment. So this right here is the beginning of a treatment algorithm from the University of Washington PALS for Kids program, and this is also where a lot of the information that's in this presentation is from. It's a great resource. The University of Washington's consultation service is great, and they provide a lot of great resources that are free and accessible online. So this is where this algorithm comes from. So if you're considering an ADHD diagnosis, you're looking at either inattention or hyperactive problems or both. So again, you want to make sure that you first rule out other potential problems like these. And again, we've gone over most of these. And then also the other thing is, remember, like we talked about first during the first session, is that the most common disorders in kids are anxiety disorders, and then after that are kind of behavioral disorders. So just remember, what are you most likely to see in kids? And anxiety is consistently at the top. So then, in terms of making the diagnosis, remembering that preschoolers will have some normal hyperactivity and impulsivity. So just need to be careful about diagnosing it too early, because that's just sort of a natural state for children, especially when in the preschool age. And if there's a rapid onset of symptoms, meaning there was no issue before, and then within a month, all of a sudden things change, not likely to be ADHD. And then using the criteria, you have to have, again, the symptoms present in one or more settings, in more than one setting, I apologize. And then really, best practice would be to get an ADHD scale from both home and school. So asking parents and teachers for feedback. If there's no significant medical history, there's no really need to be doing a lot of tests here. If there is concern for cognitive impairment, then it'll probably make sense to get some other testing. So again, if ADHD is diagnosed, on the left side here, if you have mild impairment, you can decide kind of to work with a family on on the recommendations, and this is important for both sides. But on the right, that if there's significant impairment and psychosocial treatments aren't helping, then we kind of continue down this path. So on the left, again, less impairment, you can get involved with psychosocial treatments like behavioral therapy, behavior management training, social skills training, classroom supports, and helping parents with resources. And on the right side, if you first rule out active substance abuse, if there is substance abuse, let's say this is an adolescent, then you may want to consider a non-stimulant. If there's no substance abuse, then you can look at Ritalin or Adderall families of stimulant medications. And then the goal is to titrate up to efficacy. So starting at a low dose and then going up every week until you see the best benefit. If there's a problem or there's side effects or is not improving, you can switch to the other stimulant class. So if you start with Adderall, you can switch to Ritalin and vice versa. And if there's still side effects or things aren't getting better, you can switch then to non-stimulants like atomoxetine, which is also known as Strattera, or the alpha-2 agonist monotherapy. So alpha-2 agonists are guanfacine and clonidine. And again, if there's no improvement there, then you can reconsider the diagnosis, make sure you actually have ADHD, or can start combining medications. So you'll have this resource again here on the slides, but also you can look it up on the PALS for Kids website at the University of Washington. This is where, again, I got the table. Here's a list of short-acting stimulants. You'll see again, these are all either Ritalin family or Adderall family. And these are the many different kind of formulations. Ultimately, one is not better than the other. It really ends up being what the patient can best tolerate in terms of really side effects. These are extended release stimulants. Again, here you see the entire, the beginning of the entire list of the extended release stimulants. Again, same thing. These are all either Ritalin family or Adderall family. And here's the rest of that list. And again, one of the things that's at least critical in my practice is I try to focus on essentially cost is a big issue, right? So if available, the non-brand or generic forms of this would be favorable if they're cost considerations, because again, fancy new kind of formulations of the old school stimulants like Ritalin and Adderall, the new formulations aren't necessarily better. They're released differently in the body, and so again, I think cost needs to be something taken into account. So if they're generic versions, that would be preferable. Here's some more extended release stimulants. Again, as you can see, lots and lots of sort of rebranding and reformulating of stimulants. And here's some more. Now, in terms of non-stimulant medications, really what you're going to see is there's Strattera, there's clonidine, and guanfacine. And you have this newer version of the viloxazine that again, I've actually not used this one, but in general, what you're going to see mostly in practice is the three non-stimulants that are most widely used as atomoxetine, clonidine, and guanfacine. The ones that are FDA approved are the long-acting versions of these. So again, guanfacine XR as well as clonidine XR. These are the ones that are FDA approved for ADHD. Okay. So here I want to just transition over to learning disabilities, in particular reading disability. And the reason I bring this up is because I've seen it happen more frequently than I'd like, that ADHD gets diagnosed without folk paying attention to perhaps a reading disability. Again, learning disabilities and ADHD travel together a lot. So I think it's important that we at least screen for these problems. So what I did is I put together a list here of signs of reading disabilities at different ages. So in preschool years, the most common presentations of reading disability can be having difficulty learning common nursery rhymes like Jack and Jill, difficulty learning and remembering the names of letters in the alphabet, being unable to recognize letters in his or her own name, mispronouncing familiar words, and persistent sort of baby talk, not recognizing rhyming patterns like cat, bat, and rat, a family history of reading and or spelling difficulties. So dyslexia does run in families. Years kindergarten and first grade, you'll see reading errors that show no connection to sounds of letters. So for example, the child will say puppy instead of the written word dog on an illustrated page with a picture of a dog. And so again, just kind of swapping out words, not understanding that words actually come apart and there are different sort of parts and pieces to words, complaining about how hard reading is or disappears when it's time to read, history of reading problems in parents or siblings, can't sound out even simple words like kind of these one-syllable words like cat, map, and nap, doesn't associate letters with sounds like the letter B with the B sound. And then signs of reading disability beyond those years, so ages grades 2 to 12, being very slow and picking up reading skills, reading is slow and awkward, difficulty reading unfamiliar words, often making wild guesses because he or she can't understand or sound out the word, not seeming to have a strategy for reading new words, and avoids reading out loud. In terms of speaking, searching for specific word and end up using vague language like as stuff or thing without naming the object. A lot of pausing, hesitating, and using lots of ums when speaking. Can confuse words that sound alike and saying tornado if they see volcano, or saying lotion instead of ocean. And then impact on school and life, difficulty remembering dates, names, telephone numbers, and random lists, struggling to finish tests on time, extreme difficulty learning a foreign language, poor spelling, messy handwriting, and low self-esteem, especially around school performance. And that's the presentation. Any questions about ADHD and or reading disabilities? So question for the group. Right now, what, if anything, are you seeing done around screening between kind of screening for learning disabilities, either as part of the ADHD evaluation or not?
There is a question in the chat box. For children under 6, what form do you use to evaluate? Question mark Connors.
Yep, the Connors scale, there are a number of scales for ADHD. And again, what I would caution is, definitely checking and screening for under age 6, but just being cognizant that that's still kind of on the cusp of a difficult age to diagnose just because of how young they are. But certainly the Connors scale is one that can definitely be used. So I have a question: do folks have any resources or understand what resources are available for screening for reading disabilities in your communities? I guess that's a question. I mean, how much do you all encounter reading disabilities or learning disabilities at all? Love to hear from anyone.
Mary, can we launch a quick poll? Just ask if there is, how prevalent is learning disabilities in your practice with high, medium, low? Something simple. And then there is another question in the chat box. You were just disappeared on me while Mary's putting together that poll. You were discussing how other disabilities might look like ADHD.
Yeah, Kim, do you mind elaborating a little bit? So it says you were discussing how other disabilities may look like ADHD. Can you elaborate? Is there a question? Many teachers will pigeonhole students and put them on an ILP. I'm guessing you meant IEP, and say they. Very suspenseful. So yeah, feel free to fill that in, or you can unmute yourself and feel free to speak. Have ADHD, so they need extended assistance and take them out of the classroom. Yeah, that's so good. That's a good point. The other thing is I've seen teachers kind of jump out and say, or they'll say to parents, your kid has ADHD, your kid needs to be medicated. And so I guess one of the things, let's see, yeah, and we'll jump to the next comment in a minute here, but certainly I think relying only on a teacher's observation obviously would not be best practice, right? So ideally we can get feedback from a couple of teachers or school staff as well as home, because if the child needs to be diagnosed with ADHD, the child needs to show difficulty functioning in 2 settings, right? So it has to be at school and at home, right? If the teacher's saying that there are problems at school, but there are no problems at home, then you have, then really you don't necessarily have ADHD. There's something else going on that we need to understand. And so what's happening at school that's making things so difficult? Is it bullying? Is it a reading disability? Is it another learning disability? So that's an important question to ask. Next, it says, I worked with a student who was early elementary, who was diagnosed with autism very early on, but also put on meds for ADHD. Every time he was put on a new med, it would only last for about 3 days per parents. And the idea is how to help parents stick to a med for a lot of time to see if something actually works, or can it be seen to be not beneficial within about 3 to 5 days. So first of all, in terms of autism, certainly autism and ADHD can coexist. I've seen some research to show that sometimes children with autism might be more susceptible to side effects of medication. So that's just something to keep in mind. But again, what'd be interesting about the student that you describe here, Caitlin, is I wonder So was there in fact ADHD? I mean, again, it's possible to have both ADHD and autism at the same time. So the things I think about is, again, number one, is the diagnosis accurate? If it is accurate, the medication, remember what we said before about the medication piece. The medication, you got to start low, but then you need to titrate up because, to your point, the medications can be, the patient's children as well as adults can develop some tolerance to medication. So they need to be titrated up to full benefit. And again, the increase should probably happen week after week after week. And so if there's limited or no benefit with, let's say, starting dose, then you go up to the next dose, and then you keep pushing it higher. And then you really, there's no sort of magic to the exact number in terms of the dosing. It really has to be about really feedback from parents and teachers. Okay, is it working or not working? And do the benefits outweigh any problems or side effects that you're getting, right? That's ultimately what you want. You want the medication to do more good than harm, obviously. And that's really the measure. Next question, is there a difference in efficacy of medications or behavioral therapy in inattentive versus hyperactive type? So turns out stimulant medications have been shown pretty clearly to be superior to all other medications. So again, Ritalin, and so there's Ritalin and Adderall families first, and then all the other ones. So that's kind of the starting point. The research is pretty clear there. Now, again, there's situations where in some kids, maybe the stimulant doesn't work as well, or side effects are not tolerable. And that's where you kind of jump in with other medications. So what's interesting is Strattera, also known as atomoxetine, there's some research to show that actually some kids with learning disabilities, reading disability in particular, actually can get some improvement in their reading scores with Strattera. So again, these are kids with ADHD plus dyslexia or reading disability. Strattera actually can provide more benefit than other medications. But again, I would still go through and try the stimulants first. And then the other thing I've seen sort of suggested is that sometimes you end up using something like guanfacine or clonidine plus stimulants in kids who are especially hyperactive or oppositional or aggressive. So that sometimes can be helpful as well. But in general, there's no clear class of medication that's better for hyperactive versus inattentive types. Let's see. So the other question was Azrael seems like it's not very accessible, meaning the Connors. Do you have suggestions to access it or recommend making referral in these cases? So let me see there. Let me look up. I believe I'm going to let's see. Pal's line. I'm going to find you resources, and I'm going to share this link to you. Okay, care guides and resources. Okay, so here this link is wonderful for a place to get resources. Let me see, where's the chat? Here we go. And so here they have the care guides, plus they also have a list of rating scales. And here they have the Ames, Vanderbilt. So it's like here they have the Vanderbilt as well as the let's see, the pediatric symptom checklist. And it looks like we can go down to age 8 here. Yeah, that's a good point about the Connors. And I'll tell you kind of what I really, The Conners, as you can imagine, the Conners scale, like some of these other scales, really what they do is they take the actual criteria from the DSM-5 and turn them into questions. I mean, ultimately. So really, most I don't often use scales simply because I go through all the criteria with the families, and so I would that's kind of where I would probably go with. So you can either go through the criteria sort of one by one and say, all right, these are hyperactive impulsive criteria, these are the inattentive type, and then I kind of go through them and say, all right, which one of these? And sometimes what I'll do is I'll say, which one of these does your child not have? Because sometimes they'll come in and say, oh, my kid, he's got all these things going on. I said, okay, we're going to go through this list. Which of them do they not have? And we'll see kind of how they respond. And then we'll try to find out kind of what happens in the school setting as well. But then I'll ask, so how do these cause problems? When you're telling me about these symptoms, how do they present as problems? How do they make life more difficult? And that's kind of where I get some more detail to flesh out the diagnosis.
We are ready for that poll. If you are, we can launch that about the reading disabilities to kind of tag on to how those intertwine. Okay. Do you want to share the results, Mary, or is everybody already seeing it? Awesome.
Thank you. So it looks like, so it looks like low to medium, a few have seen high. I'd also wonder about, resources. Do folks know how to access resources or know how to get a child evaluated for dyslexia? Because I found that can be pretty difficult. Some communities do better than others with these resources. I mean, I'd say Montana in the last 5 years, I've seen a few more resources sort of emerge when it comes to helping folks screen for dyslexia and provide interventions. Quick question here. What are contraindications to using stimulants as first line? And then how do you decide which of the non-stimulants you start with? So I would say if it's true ADHD, there are very few overt contraindications, right? If you have a child with, let's say, severe and significant heart problems, that's certainly something to consider, and you need to work kind of with a pediatrician to make sure that stimulant is something that's something you can and should prescribe. Some people have worried about giving stimulants to kids who have a hard time sleeping. Some people have worried about giving stimulants to kids who have anxiety. Others, hallucinations. And what I would say to that is, typically when I've seen kids with both ADHD and anxiety, more often than not, I've actually seen the anxiety go down when a stimulant is started. Again, if they truly have ADHD, because the ADHD and the difficulty functioning, actually, I've seen feed the anxiety and make anxiety worse. So, so again, you have a child who struggles with anxiety and ADHD, they really struggle in school, then they're going to struggle even more, and be more anxious if they're having trouble in school. So if their school performance starts to improve and they can focus better, I've seen the anxiety go down. In terms of sleep, it's a mixed bag, but it's again, if you're looking at real ADHD, you'll sometimes see that sleep may actually improve once you start treating the ADHD. So it's not always true that by starting a stimulant it actually impairs sleep. I'd say maybe a place I'd worry. Oh, sorry. Then the other one is kind of hallucinations. Again, hallucinations in kids is pretty rare. If if you do see hallucinations or you hear about it in a young child, more often than not, they're not really hallucinations. They're more related to anxiety. I guess a child with failure to thrive maybe doesn't weigh as much as they should, or is really low weight, or possibly even an eating disorder. That's a place I might worry about providing a stimulant medication. And then deciding which non-stimulant to start with. I tend to start with Strattera. If I'm not getting any benefit at all from a stimulant, I tend to go to Strattera and dose it twice daily, because kids have pretty high metabolism when it comes to medication. So I'll give them Strattera twice daily. I'll split up the dose. Sometimes if I do get some benefit out of the stimulant, but not as much as I'd like, sometimes I'll add kind of the alpha-2 agonist like a clonidine or guanfacine. And I'm looking at feedback here saying really difficult in the Kalispell area to get kiddos screened for dyslexia. Don't know the resources to have them evaluated. Even adults who were not previously diagnosed but clearly have reading deficits. And then from Shayna, your earlier question, screening for learning disabilities, probably looking at ADHD diagnosis, has been very limited when I've been in a school system, very limited resources in Butte. So what I'm gonna share something with you guys. I guess I hadn't looked in a while, and I was kind of getting ready for today's talk. I'm gonna share a tool for you guys here. Let's see. Dyslexia screening, Shaywitz. So here it is. So this is a dyslexia screening tool. Now something has to be purchased, unfortunately, but so Dr. Shaywitz, Sally Shaywitz and Bennett Shaywitz are two physicians who actually spent their careers studying dyslexia, and they created this screening tool for dyslexia. And actually, I would recommend taking a look at this tool. Looks like they created this in 2016 and have updated it most recently in 2021. And it looks like this assessment can also be done over the web, also online. So this is nice in that you don't need to necessarily have a patient come in person to do this. And the other thing that's nice about a screener like this is you don't always have to refer people for neuropsych testing, right? Because I would suggest that sometimes we overuse neuropsych testing, because if we're trying to screen for dyslexia, right, rather than putting a child through a 6-hour or 8-hour test and you won't see results for 2 or 3 months, maybe we can get around some more targeted screening like this dyslexia screening tool. So it could be something that could be of use. And actually, Montana, let me see, Montana, there's a website. I don't know if you guys have seen this. Let me pull up.
And if anybody knows the websites that maybe have a list of dyslexia resources for the other states, if you put those in chat or you email them to me, I will share those with everybody when I send a follow-up email to this meeting, probably Monday, Tuesday-ish.
And so here we go. I just sent the link for Montana. This is called Decoding Dyslexia Montana, and they have a list of videos, resources. I think they also have a list of folks who will do dyslexia screening and interventions. And there, by the way, if you do come across dyslexia or reading disability, there are evidence-based interventions. Essentially what needs to happen is a child needs to be taught what's called phonemic awareness. And phonemic awareness is sort of, it's really much related to, many of us were taught phonics. Well, that's a real thing. And phonemic awareness is a real thing. It's really understanding that words are made up by individual sounds rather than just kind of these big blocks of information. So again, there is research-based interventions. There are research-based interventions that can help improve reading in children with dyslexia. And so, so I would make sure that if you do discover some resources, just make sure and ask about, what approach is used, and make sure there is an approach that is being used, and not just any English tutor will do. That's I guess the point I want to make. Other questions, comments? So good. Again, I hope this was useful. Again, the sort of big takeaway here, again, remember, overall, we want to get comfortable with what's most common in child psychiatry. Most common, number 1, anxiety, number 2, behavioral disorders, and number 3 are mood disorders. Right, and after that, substance use disorders. So always making sure that you have in mind, what are you most likely to see when people show up at your practice? So that's number 1. Number 2, right, anxiety, yes or no, ADHD and behavioral disorders, yes or no. If you come across ADHD, let's also, think about, let's not forget learning disabilities, because they travel together. And so, so that'll be critical too, because and again, asking about that in family history, because if you're able to identify a reading disability and there's not truly problems with, attention, it's really more of a reading problem, you're going to save a child and a family a lot of heartache and struggle. And again, the other piece here is that kids with dyslexia and ADHD have a ton of strengths. I mean, when I was learning sort of years ago, because I went to med school where Dr. Sally and Bennett Shaywitz actually work, and I developed an interest in dyslexia and understanding it early on, sort of, gosh, some 15 years ago. And it's they really emphasize. I mean, if you look up famous people with ADHD or famous people with dyslexia, you're going to see some incredibly talented and gifted folks. And so sometimes ADHD, I think, is kind of something that's left over from, I don't know how many of us were designed to sit still for 8 hours a day. I know I wasn't. And so we're expecting our kids to sit in a classroom for 8 hours a day. And if they don't, there's a problem or a diagnosis. So that's not awesome. So I think, really keeping in mind, what are some strengths and how do we play to the child's strengths, I think is as critical as it is to kind of sort of fix the quote unquote problem. It looks like, Caitlin, I know that University of Wyoming has a program that can loan tools and has online resources like books, textbooks, and that can help in the classroom for kids with dyslexia. Cool.
And Dr. Arzubi, do you want to maybe just do, maybe since, this is kind of a smaller group, maybe since we have a few minutes and the questions are dwindling, maybe do a little bit of introductions?
Sure, to see who's out there.
And what kind of organization they work in, or?
Yeah, that'd be great. So yeah, maybe if you guys, I mean, clearly it's a very shy group because nobody wants to use a camera, so that's fine. But if you guys want to, at least a few, you put the picture up there, so that's good. If you guys want to kind of throw out there, even on the chat, tell us who you are, where you're from, and kind of what do you do? I mean, are you, again, I'm wondering, are you sort of a therapist, counselor, a school-based professional? Okay, we got occupational therapist in Hamilton. Lindsay, thank you. We should record this, because we're recording this, so I can always pick on people and I'll know who they are and where they are. Come on, who else?
Right.
LCSW in Butte, LAC, there's Shayna, yep. Amy, a pediatrician in Honolulu, pediatrician in Waimea, the Big Island.
I'm Shanda Losiema, family medicine physician for Eastern Aleutian tribes in Alaska.
Great, Shanda, thank you for being bold and getting out there, thank you. Jen Quyen, complex care, Logan Health, nurse. We have an LCSW in Maui, or on Maui. Behavioral health manager in family medicine in Rock Springs, that's Melissa. Oh, this is cool. Good. Now you guys are becoming human to me. This is good. It's not just little blocks that say Kimmy, Donna, Emily. That's good.
And, just to remind everybody, I was absent for the first session, so you weren't used to me like piping up and and rallying the troops, but we do want to hear your specific patient cases. And so if you have a problematic case, it doesn't have to follow our schedule. If you have something totally outside of what the actual didactic content is for the day, feel free to shoot me an email. That it's not onerous to present a case. It's just real high level. Oftentimes you have a very specific question, and we can give that to Dr. Arzubi beforehand. He might even have a chance to research if he doesn't know it off the top of his head. Because, you know, as we work across multiple disciplines, we all don't know what each other knows. And somebody from a psychologist might have different ways of treating. And so we want to highlight those cross interprofessional learnings.
Thank you for that. And we have a couple more. We have respiratory therapists at North Bighorn Hospital in Lovell, Wyoming. Diabetes Psych NP at Hawaii on Oahu. Patient advocate with a nonprofit in Wyoming. Pediatrician, child psychiatrist in Honolulu. Okay, I want to go back to the person who was the Diabetes Psych NP, and that name looks awesome. I'm gonna try to pronounce it because I love pronouncing things. Tell me if I how close I come. I'm gonna say Ku'ulei Kuponu'uke Aloha. How'd I do?
Actually pretty good.
Okay, good. That's
Mary,
incredible. What does it mean? That's incredible. Wow. Thank you. So I said little known fact, but I actually met my wife doing Hawaiian outrigger canoeing, and I have a very deep passion and love for the Hawaiian outrigger culture. So big fan. So good. Maybe next time I go to Hawaii, one of you guys take me outrigger canoeing.
awesome. Thanks for participating, everybody.
Cool. Thank you, guys. Actually, it's a great idea, Amber, to have people introduce themselves. I do have humans on the other side. It's great.
Yep.
Awesome. Well, thank you all. Really appreciate everybody's attention and participation. Yeah, and I look forward to keep getting to know everybody.
Okay. We'll close it down for the day then, and we'll see you back here in 2 weeks. And I will send out the slides and requests and stuff like that next week. So, bye-bye.
Bye, everyone.